All righty, we're away. Welcome to today's episode of Zedu Coaching Corner. I'm your host, Suean Pascoe. If you want to get more of this sort of education material and you haven't yet subscribed to our YouTube channel, head on over there and subscribe. And for all the ultrasound educators up there, we have a Facebook community called the Focused Educator and Seed Support Network that you can join us on and ask questions there. I want to let everyone know that this session is being recorded and it will be available on our website in the next few days, along with all the previous episodes of the Coaching Corner under the Resources tab on the homepage at ultrasoundtraining.com.au. Feel free to ask questions if you like, and if you'd rather and you're a bit shy in front of the camera, we can always come back and take those questions offline at the end. So let me know and we can come back to that. If you wouldn't mind muting your microphones now. And before we dive in, I wanted to just let you know we're hosting the Train the Trainer course again in Melbourne on November 25 and 26 of this year. If you can't make it then, it's running again in May and November next year. And we have taken this on the road to America. I've done one on the line to Denmark, Longreach, which is a little town in the middle of nowhere in Australia. So it's possible to take this on the line if you can't make it to Melbourne, but you have a group of people who are interested in learning how to teach better. Train the Trainer course is all about how to structure your ultrasound teaching to make learning easier for your students and to simplify life for you. So for a full breakdown of the program there, head over to our website again at ultrasoundtraining.com.au. Look under the courses tab under the instructor courses tab. Now, tonight's topic is how to scan the liver. We are going to first run through the sonoanatomy of the liver, how to prepare your patient, how I go about doing a survey scan, and then some tips and tricks for scanning. And last of all, I'm going to finish with the imaging sequence. So the liver is a big organ and we've got a lot to get through. So we'll tuck on in. So first, we're going to start with the sonoanatomy. I quickly found this slide here just to remind you that there are anatomical variants of the liver. The liver can come in many shapes and sizes normally, and if it's not normal, it can be different shapes and sizes again. So some people have a very, very small left lobe. Others have a saddle-like looking liver. Others, again, have a tongue-like projection or a Rydell's lobe that sort of extends down on the right. You can get grooves in the diaphragmatic surface. And so it's important that you have a quick refresher of what those anatomical variants look like as you start to scan the liver so that you've got that picture in your mind to recognize those different shapes as part of the normal variation in the liver anatomy. Now we're going to attack the sonoanatomy, if you like, by looking at the blood supply to the liver. The liver receives its blood supply from two main sources, the hepatic artery and the portal vein. The hepatic artery is a branch of the celiac trunk and it arises from the abdominal aorta, and it carries the oxygen-rich blood to the liver so that the liver can actually do its job of metabolism. The hepatic artery supplies about 25% of the total blood supply to the liver. It branches into smaller vessels, and there's an arterial branch that goes to each lobe of the liver. The portal vein, on the other hand, is formed by the union of the superior mesenteric vein and the splenic vein, and it carries nutrient-rich but oxygen-poor blood from the gastrointestinal tract, spleen, and pancreas to the liver. And so 75% of the blood supply to the liver comes via the portal vein. That blood is rich in nutrients that have been absorbed from the intestines, which are then processed and metabolized in the liver. Inside the liver, the branches of the hepatic artery and portal vein will run together through the portal triads, which are the functional units of the liver. And each portal triad consists of a branch of the hepatic artery, a branch of the portal vein, and a bile duct. Now, after undergoing processing or metabolism in the liver, the blood then exits through the hepatic veins, which ultimately drain to the IVC and return to systemic circulation. So at the top of the liver, we have the venous drainage system going back towards the heart, and from underneath the surface of the liver, the portal vein enters. And as you can see here, there are branches of both the venous drainage and the arterial and venous supply to the liver that go to each segment of the liver. So those portal veins, you can see here, the main portal vein coming in, and it branches into the left portal vein and the right portal vein, which then further branch into the veins that supply each lobe of the liver. When we look at the portal veins on ultrasound, they have quite echogenic walls, and that's because the veins are acting much more like arteries. As I mentioned, they're supplying 75% of the blood supply comes via the portal vein to the liver. And so they are unusually quite echogenic and thick-walled. And so in this left-hand image, you can see the right portal vein and the branch going down to the inferior segment there. And on the right-hand image here, you can see the branch of the left portal vein going up to segment 2 and 3. Now, the hepatic veins are a group of 3 large blood vessels that drain that venous blood from the liver to the inferior vena cava. And those veins are called the right hepatic, middle hepatic, and left hepatic veins. They arise within the liver parenchyma from the small central veins that drain the liver sinusoids. The left intermediate or middle and right hepatic veins then course between the 4 sections of the liver, demarcating the boundaries of those liver segments. And so that's why I'm starting with the vascular supply, because that's going to help us to determine how do we divide the liver into those various segments so that when we see a lesion in the liver, we can describe the location and then correlate that with other imaging. The right hepatic vein courses between the right medial and right lateral sections of the liver, comprising the right lobe of the liver. The intermediate or the middle hepatic vein lies between the right and left lobes of the liver, and the left hepatic vein runs between the left lateral and the left medial sections of the liver, comprising the left lobe of the liver. So these hepatic veins are really important anatomical and surgical landmarks because they define the sectors and the sections of the liver. So on ultrasound, they're quite thin-walled and they run kind of obliquely or vertically on the image. In this left picture here, you can see the right hepatic vein. In the middle picture, you can see the hepatic confluence. So we have the right, the middle, and the left hepatic veins. And in this picture on the right, you can see the left hepatic vein coursing out to the left lobe of the liver. If we compare the images of the hepatic vein side by side with the portal vein, you can see that the walls of the portal vein are a bit thicker and quite a lot more echogenic or brighter. And so that helps us to differentiate between whether we're seeing a hepatic vein or a portal vein. The other thing you notice about the portal veins is they run a little more horizontally. Across the middle part of the liver here, we've got this branch that sort of takes us up to the top, but each of those segmental portions of the portal vein are running quite horizontally, whereas the hepatic veins here are running more obliquely or even vertically through the liver. Now, the hepatic artery is this tiny little vessel, easily overlooked. Such an important vessel, though, because this is the one that supplies oxygenated blood to the liver. And it plays a crucial role in maintaining the metabolic function of the liver and providing necessary oxygen for the aerobic metabolism. And that's essential for the liver to carry out all of its functions. So it arises from the celiac trunk. It's a major branch of the abdominal aorta. And then it divides into the smaller branches that supply the different segments of the liver. It's really small. It's very difficult to see. And so the only time we really see it is at the porta hepatis here. So we find the portal vein, and you can see the little red dot there underneath my laser pointer. That is the cross section of the hepatic artery as it comes towards us. And indicated in yellow running across the top is the bile duct. So the hepatic artery is kind of our landmark right here for when we measure the bile duct. We measure the bile duct distal to the hepatic artery. And when you have the perfect textbook patient, it appears like this in this configuration with the portal vein, hepatic artery and cross-section, and the bile duct running across. So it's very small, very difficult to see, as I said, quite easily overlooked. The way I find this is in the longitudinal position. I'm coming out to where I see that portal vein entering the liver, and I'm looking for that tiny hypoechoic circular structure that's just above the portal vein. Now, some other anatomical landmarks, we need to think about what the ligaments are doing and the main lobar fissure, and they also help us to find those segments. So the liver is divided into anatomical and functional units called lobes or segments. The segmentation is really important for surgical procedures, for liver pathology, understanding the blood supply and drainage of the liver, and for describing where those lesions are located in the liver. So the anatomical lobes, the liver is conventionally divided into the two lobes, the left and the right lobe. The right lobe is much larger and comprises about 60 to 70% of the total liver mass. The left lobe is smaller and is divided into the two parts, the medial and the left lateral section. The main lobar fissure is a vertical plane that runs from the inferior vena cava to the gallbladder fossa and divides the liver into the left and right lobes. It can be seen in the sagittal plane as an echogenic line between the gallbladder neck and the main portal vein. Now, we've been talking about, we have left lobe, right lobe, but we conventionally describe any anatomical or any pathology lesions according to their segments. So then we can compare it with what they're seeing on CT and easily locate those segments, and so that we're measuring the same thing again and again. So those functional segments is a really detailed division of the liver into the functional segments, which is based on the blood supply, as we've been talking about, and it's known as the Cunard classification. Now, you can go and read up about the detailed anatomical descriptions of where Cantley's line lies and all the rest of it. But I want to talk here about how I simplify this, for how I put this into practice for when I'm looking at the liver. The way that it makes sense to me is that it's essentially divided into 8 sections. Segment 1 is always the caudate lobe, and that's a small lobe located on the posterior superior surface of the liver that has its own blood supply and drainage. So the caudate lobe is always segment 1. Then we have segment 2, 3, 4A and B, which technically makes it 9 lobes, but we'll go with the 8 that they always talk about. We have 2 and 3, 4A and B, 5, 6, 7, 8. Now, the way I look at this is that the liver is roughly divided into superior and inferior, or top and bottom, by the portal venous system. So if I see a lesion that's above the portal veins, I know that it's in those upper 4 segments. And if I see the lesion is below the level of the portal veins, it's in these lower 4 segments. Now, vertically, the liver is divided into quadrants, but marked by the hepatic veins. And so we have the left hepatic vein that, if we look to the left of the left hepatic vein, we have segment 2 and 3. So segment 2 is to the left of the left hepatic vein and above the portal vein, segment 3 below the portal vein. The middle hepatic vein is our next divider, and so above the portal vein is 4A, below the portal vein is 4B. And then the right hepatic vein sections off, so anything far right is segment 6 and 7, and anything between the right and the middle is segment 5 and 8. So if you find a lesion, it's all good and well to find where that is, but then we have to go back and find where our vascular landmarks are to figure out where is the lesion sitting in relation to the portal venous system and the hepatic veins. Now, a number of people use this analogy. You can kind of remember these segments by making a fist. So your thumb is section 1 or the caudate lobe, and then your first digit is section 2 and 3, above and below the knuckle, and then we go 4A, 4B, 5, 6, 7, 8. Now, the way that I remember this, and I have to think through this every single time, is that we roughly go in a clockwise direction. So we have segment 1 is the caudate lobe, and then we go in a clockwise direction to go 2, 3, 4, 5, 6, 7, 8. And like I said, I have to stop and think about it every single time. Look, some people can look at these images and just know, oh, that's exactly, and they've memorized them all. Good on them. I have to figure it out every time. So hopefully that helps you to sort out where these lesions are when you're looking at the liver. Now, some of the other useful anatomical landmarks include the ligaments of the liver. So the falciform ligament is formed by a double layer of peritoneum, and it's attached to the liver, diaphragm, and anterior abdominal wall. It supports the liver by anchoring the liver to the anterior abdominal wall and to the diaphragm. And in fetal circulation, the umbilical vein passed through it. Following birth, that umbilical vein closes and so eventually becomes ligamentum teres. Now you can see highlighted in green in the left picture, here's where the falciform ligament runs. That middle picture, you can see how you've got the fold of the falciform ligament with the round ligament or ligament teres running through it. And here's a lovely CT image which quite nicely demonstrates that falciform ligament attaching the liver to the anterior abdominal wall. Now, usually on ultrasound, we don't usually see the falciform ligament. But in this case, in this patient with ascites that's associated with chronic liver disease, it's very nicely delineated where that falciform ligament is attaching to the anterior abdominal wall. You can also see in this picture a very nodular liver surface. The fluid is actually helping us to see the liver surface and that falciform ligament. Now, ligament teres is where the umbilical, or used to be the umbilical vein, and it runs through the falciform ligament. And so if you imagine the falciform ligament here in orange, that's like a fold in the peritoneum, the ligament teres runs through it down the bottom. And so it's a remnant of the umbilical vein, and in the normal liver we just see an echogenic area. So in longitudinal we can see the ligament teres running along here, and in transverse it can have quite a bullseye appearance. And so it's really important here that you scan it in 2 planes so that you can be sure that it's not just an echogenic lesion or a metastasis, for example, in the liver. If it was a lesion, it's likely to be round in both planes, whereas the ligament teres actually runs along the length. In long, it runs and makes a line here, and in transverse, you get that bullseye appearance. Now, it's really important to sort of understand what that ligament is, because we don't want to mistake it for a lesion. But the other thing, when you have like end-stage liver disease or really chronic portal hypertension, sometimes one of the sequelae of that disease process is that the umbilical vein can recanalize and you can get umbilical varices. And so if you see that sort of hypoechoic vessel running through where the ligamentum teres is, it sometimes in transverse has a bullseye appearance, and if you pop the color on, you'll see that blood flow and the umbilical vein recanalized. Now, the last ligament that we're going to talk about is ligamentum venosum. It's a dense band of fibrous tissue that's a remnant of the ductus venosus of fetal circulation. And so in the fetus, it's patent and it's shunting blood from the placenta via the umbilical vein to the IVC. And once Bub's born, it closes off. But what we see is a remnant here, and it's nice because it helps us to define the edges of the caudate lobe of the liver. So let's move on to the scan. We like to have our patients fasted 4 to 6 hours to reduce the bowel gas. And my preference for abdominal scanning is to scan patients in the morning if you've got an option, again, in an effort to reduce the bowel gas and to make our windows better to get better imaging of the liver. Now, the next thing we're going to do is get our machine set up. And so we want to remember the 3 Ps. We're going to use the curved probe. Choose an abdominal preset if your machine has, sometimes they'll have an abdominal preset and maybe difficult abdomen. The difficult abdomen preset is for your larger patients, and it will adjust the frequency and optimize the imaging for the larger patients, or for those thin patients who have a fatty liver. And lastly, we'll pop our patient details into the system so we can keep a record of the images. And then I start with the survey scan. Now, before I get set up here, what I do is go to the midclavicular line in longitudinal and get a nice length of the liver, and I set up my parameters. So the first thing we're going to think about is the frequency. Now, your preset will generally come up with it on a preset that's optimized for your average patient with a mid-range frequency. If your patient is larger, you may need to switch to a penetration setting or a lower frequency. Or if you have a thin patient with a very fatty, dense liver, you may need to use a penetration setting. If your patient's nice and thin, or you have pediatric patients, you might get away with a resolution setting or a higher frequency setting. The next thing we do is adjust the depth so that we can get the whole of the liver on. And so typically for your average patient, I usually start at about a 16 centimetre mark. If you have the depth too shallow, you're going to cut off the liver. If you have the depth too big, there's a whole waste of space here, and we are not optimizing our field of view the best that we can. The next thing we're going to adjust is the focus, and we want to set the focus at the back of the liver so that we can see through all of the tissue and get good imaging all the way to the deepest part of the liver. Of course, if you're looking specifically at the liver surface, then you would then adjust your focus and bring it up into the near field so that you get better definition of the liver surface. I also adjust my gain settings here and optimize them. So the overall gain, I don't want it too dark, as we've got depicted here on the left, or too bright. And it's too bright if you're kind of blinking at it and need your sunglasses on, you need to wind the gain down. We're aiming for an even shade of grey across the liver so that the whole way through the liver tissue is the same shade of grey. Now, what that means is sometimes you need to increase the time gain compensation more in the far field, because as the sound leaves the probe, it starts interacting with tissue, and the further that it has to travel, the more it's interacted with the tissue and the more energy it's lost. And then, of course, it has to echo and come back, and the same processes happen on the way back. And so often you'll find, and particularly for your fatty livers, you need to wind up the gain in the far field to achieve that even shade of grey across the whole field of view. It's also important to check and make sure that your TGC is set smoothly so that we have even shaded grey across the whole field. If your slide pots or your TGC are set inconsistently, with some of the slide pots really one side or the other, you can actually create artifact and start to create lesions that aren't real. So it's important that you do just double check that TGC to make sure it's smooth across the whole image. Now, the other things from a technical point of view, we need to slide as high as we can up into the xiphisternum to get closer to the liver. Now, the liver sits quite high under the ribs, and you'll also need to rock your probe to put it in the center of the field of view. And as you can see in this clip here, if we imaged with our probe rocked down, here's great. But if I play it again, where we started, just here, we're cutting off a whole heap of liver. So you want to rock your probe to position the anatomy in the center of the field of view. Now, most of my liver imaging is done with the patient taking a big breath in, and it's coordinating that breathing so that you get the best imaging. So I typically scan on one big breath, scan the left lobe of the liver, have the patient breathe. Okay, breathe in again. I hold my position with the probe. Breathe in again. The liver comes back into the middle of the picture, and then I scan through the right lobe. And I might need to take 2 breaths to get the whole way through, depending on how quickly you scan. But it is really, really important because, as you can see, it pushes the diaphragm down and it brings the liver into the field of view much better. So my scan technique, I recommend scanning the liver both in the supine position And in this case, I'd pop the right arm above the head. That will just separate the ribs a little bit and help us open up the windows. And then I also do most of the imaging of the right lobe of the liver. I'm scanning in the left decubitus position. And what happens in that left decubitus position is the liver slides or falls slightly medially and brings it out from under the ribs a little so that we can get better windows. So I start by placing the probe in the longitudinal orientation with the probe marker to the patient's head. I put it just under the xiphisternum in the midline. From here, I'm going to rock up to get the anatomy in the middle of the picture. And then I'm going to sweep my probe until I bump against the ribs. And then I'm going to fan the probe out to get all the way to the lateral margin of the liver. And then work my way back through and back to the midline position. Now I do all of that on one big breath in, sweep through all the way to the lateral margin, and then I come back through to the IVC, and then I get my patient to breathe, and then we start again. Big breath in and move on to the next view. So that looks like this. I start in that nice triangular portion of the liver, scan all the way out to the lateral margin, and then coming back through towards the midline and towards the IVC just here. The next thing I do, maintaining that probe position with the probe rocked up so that the liver is in the center of the field of view, I'm now going to follow that costal margin down to about the mid-clavicular line. And then I'm going to fan out to the lateral margin of the right lobe of the liver. Now, some patients, you might need to do this a couple of times to see all the liver. You might need to rock up to see the top part near the diaphragm, rock down slightly to see the inferior surface of the liver. Depends how big their liver is and how much you can fit on that one field of view. So once I've scanned that right lobe of the liver, I get the patient to breathe again. And so we're starting at the IVC, we're sliding down and following the subcostal margin, get to about the mid-clavicular line, and then I fan all the way out until I get right past the lateral border of the liver. Now, we also need to take a measurement of the liver, and this is done at the mid-clavicular line in the supine position. We need to be able to determine whether the patient has hepatomegaly, and the liver measurements need to be consistent to be able to compare their liver size over time. Caliper placement needs to be positioned in the same position no matter who is doing the scan. And so it's really important here to ensure consistency between different operators, that you know what your departmental protocol is and how to do the measurement in the same way that it's been performed before. And so it should be taken in the supine position at the mid-clavicular line, where you see the biggest margin of the liver tissue here. Now, what we're going to do is draw or imagine a line here that marks where the liver tip is, and we're going to take a vertical measurement from the diaphragm all the way to where the liver tip is. Now, there are many different ways to measure the liver. So this is not how I learnt it, but this is the current thinking on how to measure the liver. There are many different ways to measure it. I've read in some papers that even, it doesn't matter which way we measure it, it's not particularly accurate if you measure it against a cadaver specimen. The important point here is that we have a consistent method for measuring it so that we can determine for that patient whether their liver size has increased over time. And it also helps to build a reference point for understanding whether that's a normal liver size. Now, the other things to look for to see whether the liver is enlarged is to see if it starts to bulge convexly this way. And so, or, have a blunted end of the blunted liver tip here. And that starts to suggest to me that perhaps the liver is large. If it's measured in the way that I have depicted here, it should be about or less than 16 centimeters in the adult. So be careful here not to get confused with the Rydell's lobe and measure the Rydell's lobe. It can be a bit challenging, but it's important to practice measuring it so that there is consistency between sonographers and so that you build up your pattern recognition skills. Now, the other thing I do at that mid-clavicular line point is compare the echogenicity of the liver to the kidney. In the normal liver, the echogenicity of the liver should be isoechoic or about the same as the echoes of the kidney. If the liver is much brighter or your kidney appears quite dark in comparison, then that is also indicative that this is fatty infiltration of the liver. Now you can see in this image in the right, it is quite a bit brighter. The liver texture is brighter than the kidney, but it also looks a bit fuzzy in this deep portion of the liver. And that's because the sound is being attenuated so much that we just can't get enough energy through to that deeper portion of the liver. And that's another classic sign of fatty infiltration of the liver. Now we move on to the transverse scan of the liver. So again, I'm going to start in the xiphisternum area as high as I can, as high as where the probe can fit. And I'm going to be fanning up towards the patient's head. And we're going to fan towards the superior surface of the liver and then inferiorly to the inferior margin. I need to try and see the whole of the left lobe of the liver. So I need to position my probe so that I've got all of this edge as much as possible on the liver, on the screen, I should say. And so you can see here as we fan up, we see the hepatic vessels. There's the heart, hepatic veins on the top, coming down a little further. There's the portal venous system and down to the inferior aspect of that left lobe. I then move my probe over and align it roughly with the costal margin and fan superiorly towards the head to see we're looking at the middle section here. So between the left hepatic vein and the middle hepatic vein, I want to do a sweep just in that section to get section 4A and B. And so we fan up and then you rotate your probe back to a more conventional transverse orientation and then sweeping down. And so what that looks like, we fan up to the heart, coming back down, being sure that we can see between the left hepatic and the middle hepatic veins, all the way to the inferior surface. And then I reposition my probe again, and I want to scan through the lateral right part of the liver. So this will be, again, a combination of a fanning motion and a sweeping motion, depending on how big your patient's liver is, and depending on the window or where it sits, how far up under the diaphragm it sits. And so you can see here as we fan superiorly up to the top of the liver and the heart, coming all the way back down, all the way through hepatic vessels, portal vessels, and down to the inferior surface and beyond that lower portion. And so if I play this again, we want to make sure we get as much diaphragm on this left side to see the very lateral portion of the liver there. So you may need to rock your probe to the left to make sure your liver tissue is positioned centrally in the field of view. Now, the next thing I do is always go up and have a quick look at the intercostal views. And I do this for every single patient, even the ones that I think I've seen the liver really quite well. And the reason is that I need to be practicing this technique for those patients where I just get absolutely rubbish views subcostally. I want to build my confidence in my imaging skills and know that it's a bit difficult to find everything that I need, but just practice that technique. And so what we do is just position our probe at different ribs, and we're fanning through and exploiting the window as much as we can, then moving to the next rib and trying to get a little bit of overlap between the tissue. And so it's not terribly satisfying. It's not as good as looking subcostally for this patient, but on some patients, this is the only view you can get. And in fact, I remember one time I was scanning a patient and I thought I got great views of the liver, and I took my films through to the radiologist, and he looked at me in horror and was like, "Suean, this patient's had a CT scan that shows a 5-centimeter lesion in the liver." Back you go. So I go back in to my patient and I'm getting him to breathe in, and he's going blue in the face, breathing in so much for me. And I really tried hard to find this liver lesion, and I'm like, I cannot see it. So I went back to my radiologist and said to him, you know, if you think it's there, can you come and show me how to do it? And he really, really struggled as well. And we ended up in a position that was, the probe was just about in this patient's armpit. And even then, we're going intercostally. Even then, you kind of had to squint and imagine, because we knew where it was on the CT scan. So because we knew where it was, we kind of had to squint a bit and think, oh, it's likely that lesion. But that's section 6 and 7 of the liver. Those lateral portions are very difficult to get good imaging. So practice your intercostal views to help you with this. And lastly, before we leave, we're going to just swap over to the linear probe. And I want you to take a picture in the midline for the left lobe of the liver and in between the ribs somewhere on the right side, specifically looking at the surface of the liver. It should be smooth, okay? What we're looking for here is any bumpiness or nodularity, or for your cirrhosis patients, it almost looks like they have rice bubbles under the liver surface and a little bumpy liver surface. And using the linear probe with the higher frequency allows us to just concentrate on the liver surface. We are not going to see all the rest of the tissue. It's just about looking at the surface. And it's interesting to see how many times when you do that, you'll get a much better appreciation about the surface than if you just use your regular curved probe. So some technical tips. I have described to you my method for scanning the liver. As always, I'd really encourage you to check your local protocols. There are some sonographers who are very set in their way about how they do things. And if you're scanning with them, they may suggest a very different technique. And that's okay. As long as you see all of the liver tissue, you've looked at it from a couple of different windows, and you've also looked at it from a couple of different positions. And as I said, I start with it supine, do that whole series, and then roll them on the side and then scan the liver through again. So I've seen it from a couple of different windows. One of my colleagues in the office here says she scans her left lobe in the supine and images the left lobe in the supine position, quickly has a look through the right, but then rolls her patient onto the left side, scans the left lobe again, but then images the right lobe in the decubitus position. Another colleague of mine started with the right lobe of the liver and worked her way through medially. I've seen another colleague who has done the whole liver, a whole left lobe of the liver in one shot, because you optimize the depth settings for the left lobe and then adjust the depth settings for the right lobe and then scan the right lobe in long and trans. There are many different ways to skin a cat. The important thing is that you look at the window, you look at the liver from more than one window and in more than one position, and that you scan through and see all of the liver tissue. The reason I do it the way I do is I want to minimize how much my patient is rolling around, particularly for your elderly and frail patients. It can be quite the challenge getting them rolling around a lot. And I also just want to minimize how much time it takes me to get all my pictures. I'd encourage you, if someone does it a different way to you, ask the question, what's the rationale for why they do their liver series that way? They may have a good reason, or sometimes it might be because that's how they were taught. So try to understand why they're doing it a different way to you. Eventually, you'll develop your own technique. Now, another thing you can try is to do a belly out maneuver. So get your patient to sort of bear down or to push their tummy out. What this does is push the diaphragm and the liver down lower in the abdominal cavity so that you get a better window subcostally. And then also look from different windows. So we start in that xiphisternum. You might go subcostally, midclavicular line, infracostally, and intercostally. So try from different windows and see what you get. Those intercostal views are not the most satisfying, but on some patients, that's all you've got. So make sure you do practice. Now, lastly, I wanted to just run through, here's the sequence of pictures that I take. So I start in a longitudinal plane. My first image is the left lobe of the liver in long, and it's a triangular shaped bit of tissue in the midline. Then I start, I've swept through and evaluated the whole liver with that survey scan first to find where the pathology is before I then go back and then just snap off the pictures. So a normal liver would be the left lobe. This next picture is at the caudate lobe. And you can see the ligamentum venosum here. Then I move on and take a picture at the IVC. Then I move on. This is at the mid-clavicular line, and that's where we take the measurement. The next picture I take is comparing a big portion of the right lobe of the liver, but making sure I've got kidney on the image so that my reporting radiologist can actually compare the echogenicity for himself. And the last picture in long that I take is a little more laterally than that kidney picture, out as far as I can get laterally. So those are the long sequence: left lobe, caudate lobe, IVC, the mid-clavicular line to take my measurement, the right lobe of the liver with the kidney for the comparison of echogenicity, and then the far lateral right lobe as far out as I can get it. Then I move on to the transverse imaging sequence. I start with the left lobe and at the hepatic artery. The next picture is at the portal veins in the left lobe. So you can see here, here's the branch, and you can see one, this would be the segment 2 portal vein and segment 3 portal vein. Then I take a picture at the hepatic confluence. This is such a satisfying picture to get. I used to think they looked like a bit like bunny rabbit ears or the tree, but we want to see all the hepatic veins draining into the IVC. Now, often you do need to be a little bit oblique on the body or about the level, following the line of the costal margin to get this picture and fanning quite superiorly. My next picture is the right hepatic vein. Now we need to often thumb down a little bit here to lengthen out this hepatic vein and get as much tissue over this way towards the diaphragm as we can. Then I sweep down to demonstrate the right portal vein. And the last picture in the transverse is coming beneath the portal vein. And again, we've got that comparison here with the right kidney. So the transverse sequence is the left hepatic vein, the left portal vein, the hepatic confluence, the right hepatic vein, the right portal vein, and then inferiorly comparing the echogenicity of the liver to the kidney. So that's a lot of information, but that's how I go about my scanning of the liver. We've covered off on the sonoanatomy, and that very much guides our imaging sequence and our understanding of how to sonographically locate lesions and define their position according to the Cunard's liver segment classification, so that we can compare it with other imaging. We've talked about the patient preparation. We're like a fasted patient, and in the morning is much better because they have less gas. I do a survey scan first. Now, I might spend 5 minutes scanning the liver and just scanning it and finding the lie of the land and determining, have I got any lesions? Where are they? What segment are they in? And I do that survey scan and figure out everything first before I move on and take my imaging sequence. We've also covered some technical tips here, but then that imaging sequence, the normal sequence that I've displayed to you, if all the anatomy is normal and there's no pathology, it's just bang off a series of pictures. But otherwise, we need to spend a bit of time documenting where the lesions are and where they are in relation to the hepatic vessels. So that's what I've got for you for today's episode. If you found this episode useful or helpful in any way, feel free to refer your friends and colleagues to the resources section on our webpage at ultrasoundtraining.com.au, or you can subscribe to our YouTube channel. If you have ideas for our next section, please get in touch. This topic was suggested by someone, I can't remember who now, and then we tried to find the email and I can't remember who suggested this one, but I do respond to those requests for topics. So if you've got a topic, a burning topic you want discussed, feel free to get in touch by any of these methods, and I'll see what we can do. So now I get to throw over to you in the audience to see if anyone has any questions.
Suean, hi, it's Marcus Peck. Great talk. It's really, really interesting for me because this is an area that I don't scan a lot of. And I really feel like I've learned so much. So thank you. I've got a question, and it sounds to me like the veins and the portal system are pretty predictable and in, the same place in different patients. Have I got that right?
Yeah,
Are they?
the scanning sequence, as you scan up the hepatic veins, as you fan towards the patient's head. So
Yeah.
let me just see if I can demonstrate to you. I'll lower this down a bit. Maybe I can't go that high. So,
Oh yeah. Yeah.
yeah, as you go this way towards the patient's head, hepatic veins, as you come down as portal veins. Now,
Yeah.
they might not. I have chosen perfect patient, and I tried a few to get these images. They don't
Yeah.
always look like this, all right? But this is the ideal perfect patient, and I think you need to practice on some lovely slim patients to start with to get the knack of where things are and to get your orientation, because in your
Yeah.
patients with fatty liver disease, those hepatic veins are really hard to see because they're so squished by the fatty tissue, and they're not always as pretty as that, but hey, I'm allowed to get nice pictures for my talk.
So we're really interested in some of these vessels for hemodynamic assessment, because we can look at the waveforms of blood running through them, and it gives us an indication of right heart pressure and congestion. You probably heard the term Vexus. So one of my interests is in how AI can help us to do things that are difficult. And in Echo, AI can help us to, navigate to the different views, for instance, and I'm just wondering if you can imagine teaching AI to help us identify those vessels and get them in sort of long axis such that we could then, deploy Doppler on them. How do you know this really well? So, how does that sit with you? Do you think that's, I don't expect you to be an AI IT expert, but do you think that's possible to train a computer to do this?
They've learned the heart.
Yes.
Thing is, with any of those, I know one of the guys who set up AI with one of the systems, and he has spent hours and hours and hours finding normal and coding those pictures. And
Yeah.
so, and yes, the machine learns along the way. But it's interesting. In the heart, for example, if I scan my husband, he has an aortic valve replacement, and the AI just completely cannot handle it.
Yeah.
I've got a
Yeah.
beautiful image, but the AI just doesn't work and won't then do the automatic calculations because it doesn't handle. So it's a matter of time. I don't know that they've, in a point of care world, liver, I think, is borderline. I don't think it's necessarily a point of care. It's not easy to scan because there is that variability in anatomy, and also because you need good skills to be able to do it. So it's not and it takes time. Like I said, as a really experienced user on a very normal patient, I need to spend at least 5 minutes looking at it. If you have a difficult patient, that time blows out. And in a point of care scenario, that's not really viable. You could quickly look to see if there's big dilated hepatic veins that you see with congestive heart failure. But it is a tricky scan that takes a lot of practice, and I'm talking 70 to 100 scans before you're really starting to get the hang of it. It's not one that I think you can get away with 20 or 30 scans to gain a competency in. So, I mean, I think eventually, I mean, they're doing lots of stuff with AI in many different areas. It's when liver sort of bubbles to the top as the next most pressing thing. Then the
Because I
radiologist
think
should be worried.
the targeting those vessels is quite a prize for lots of us on the ground, and I think being able to get them, particularly the portal vein, would be really, it's not the easiest thing when you're starting out. So yeah, I was just thinking, are there ways of making that little bit of scanning that you've talked about today a bit easier? But I really listened to you, and thanks very much for your wisdom, Suean.
No worries. The portal vein, I tossed up, do I include that today? But it's a topic all on itself. It's quite tricky to get portal vein Dopplers and all the rest of it. And that you do need to have really sound and solid skills to be able to get that at will. And part of this is all about, yes, I make that look easy, but it's about coordinating the patient breathing and knowing how to do that and coordinating yourself to do all that to be able to optimize the imaging. And like I said, it takes a good 70 to 100 scans, I think, to start to develop any level of basic competency in this. And portal vein is a advanced skill, certainly not for point of care, I don't think. No worries. Does anyone else have any questions?
Yes,
Henry, I
thank
haven't seen you for
you.
a while. How are you?
Yeah, I'm fine. I've missed out on 2 presentations, maybe due to network connections. So good morning from Cameroon, or good evening to you in Australia. So the presentation, I missed out on the time and I only got the second half of the presentation. But however, it is good. So I don't know, did you touch on the aspect of measuring the portal vein, the inferior vena cava, and the hepatic veins?
No,
And
not in
if you
this
did
talk.
touch on that, so where do we measure them? Do we measure the main portal vein or the IVC? If we are measuring, is it how far away from the right atrium should we do that?
The IVC, I think the convention is within 1.5 to 2 centimeters of the diaphragm, in the longitudinal scan plane, and perpendicular to the vessel. The portal vein, you're measuring at the porta hepatis, and you're looking at first, and I haven't covered that in this talk, as I said, that's a whole topic in and of itself. You're looking at whether there's hepatopedal or hepatofugal flow. So you need to understand your color Doppler principles to know whether it's running to or from the liver. And the hepatic veins, I've never really put measurements in them unless we're looking for thrombosis and using the color to demonstrate that there's no flow in there. And again, you have to have very good color optimization skills and be able to hold your hand steady to be able to do all those things. So I know as a sonographer, you probably get to do a bit of that in practice, but for point of care, I don't think it's a point of care skill. But the IVC is easy enough. Portal vein, a little trickier, needs a lot more practice, but we didn't actually touch on that one in today's talk. Well, thanks, team. Thanks so much for joining me. I know you've got up at all sorts of different hours, or maybe it's daylight for you, but it's dinner time for me. So I'm going to head off now. I do thank you for joining me. And as I said, if you have a suggestion for next month's topic, get in touch and I'll see what I can make happen. That's all from me, folks. Good night or good morning.